Good morning and welcome to the first case discussion of PT1A Group 6. In this presentation, we shall be discussing the case of a 27-year-old female national swimming athlete specializing in the butterfly stroke and was diagnosed with left rotator cuff tendinitis. The patient complains of pain on her left shoulder during movement, accompanied by some degree of weakness.
Based on the symptoms presented by the patient, we plan to discuss the following things. This includes the nature of the patient's occupation as an athlete, the relevant anatomy involved in the patient's sport, as well as the pathophysiology of rotator cuff tendinitis. Then we shall be going into more detail as we delve into the affected structures related to said condition, and how the patient's specialization in the butterfly stroke could have contributed to the development of her diagnosis. Swimming is one of the many athletic sports that involves the exertion of almost every major muscle group in the body, specifically those of the limbs. The butterfly stroke, a competitive swimming style, can be described as a bilateral, symmetrical, simultaneous overhead motion of the arms, combined with the simultaneous bilateral, symmetrical, undulating motions of the legs, commonly known as the dolphin kick. As you can see from the demonstration, the forearms pronate, the shoulders abduct, the scapulae protract and abduct, and the elbows flex slightly as the heads lead to the next phase of the stroke. Focusing on the biomechanics of the upper extremities, the lack of rotation on the torso increases the need for scapular protection and abduction in order for the arms to achieve depth in the water, which is necessary to create a powerful stroke. So essentially, the functional demands specific to the butterfly stroke required an increased range of shoulder motion.
With respect to the case at hand, let's now review the relevant anatomy encompassing the shoulder, particularly the muscles of the posterior scapula, otherwise called the rotator cuff. This is a muscle group of tendons attached from the shoulder to the upper bone or the humerus. The rotator cuff consists of the four muscles surrounding the shoulder joint, commonly abbreviated into seats: the supraspinatus, infraspinatus, teres minor, and the subscapularis. For all actions that require the upper extremities to be at or above shoulder level, these muscles and their tendons collaborate with the deltoid muscle in order to give the shoulder mobility and strength. The four tendons combine to create a cup or hood around the humeral head, which is where the cuff portion of the joint originates. The ball and socket joint in the shoulder is represented by the head of the humerus. This joint enables complete circular motion of the shoulders and arms, which prerequisite of swimming.
For further substantiation, let's discuss the functional motions enabled by each of the six muscles along with the rotator cuff tendons involved. Please refer to the table shown on the slide, indicating the origin, insertion, innervation, and primary action of each muscle. Firstly, we have the supraspinatus, which holds the humerus in place and keeps the upper arm stable while elevating the glenohumeral joint laterally. This muscle is located in the supraspinous fossa and initiates shoulder abduction. Attached to the infraspinous fossa is the infraspinatus, which holds the external rotation and extension of the shoulder. Then we also have the smallest rotator cuff muscle called the teres minor, arising from the posterior surface of the scapula, and whose main function is to assist with the external rotation of the arm away from the body. And lastly, residing in the subscapular fossa is the subscapularis, which holds the humerus to the scapula. This muscle allows for the internal rotation of the arm and aids in the adduction of the humerus. Each of these are vital muscles of the rotator cuff that compensates for overhead motion of the upper extremities and strenuous demand of the butterfly stroke in competitive swimming.
We've established the background of the muscle groups within the shoulder. Let's circle back to the presented condition from the case. Please direct your attention to the flowchart seen on the slide. The patient is a sports athlete who specializes in swimming the butterfly stroke. From this, we can infer the consistent use of her shoulder muscles, specifically the rotator cuffs, when it comes about to training and competitive scenarios. The patient reports clinical manifestations of pain on her left shoulder during movement, also accompanied by some degree of weakness, presumably from built-up fatigue or the overuse of the patient's rotator cuff when engaging in swimming activities. Based from the previously discussed information on the case's relevant anatomy, it would be well-grounded to believe that due to the over-repetitive motion of the patient's shoulders, the acromion of the scapula tilted forward, causing impingement on the tendons of her left rotator cuff during contraction of the deltoid muscle. This would explain the weakness, movement pain, and probably swelling on the patient's left shoulder area. We also believe that this framework led to the patient's primary health physician to give her a diagnosis of left rotator cuff tendinitis.
But what exactly is the medical definition of rotator cuff tendinitis? According to Johns Hopkins Medicine, rotator cuff tendinitis, otherwise termed as shoulder impingement or biceps tendinitis, is a condition which causes pain and swelling in the shoulder area, often resulting in limited range of motion and weakness of the arm. Such injuries are common among athletes with sports involving the excessive use of their upper extremities. Although macrotrauma can cause rotator cuff injuries, repetitive microtrauma, as well as outlet impingement in between the greater tuberosity of the humerus and the acromion of the scapula, are more frequent. Patients with rotator cuff tendinitis frequently note acute anterior or lateral shoulder pain that occurs with overhead activities, functional reaching tasks, or also at night when attempting to sleep. Symptoms such as stiffness or weakness of the arms might also be present.
Moving forward, let's discuss the affected structures in the shoulder area stemming from rotator cuff tendinitis. Displayed in the slide is the mechanism of impingement upon movement of the left upper extremity. It can be seen that when the arm is abducted to 90 degrees and maximally externally rotated, contact begins between the undersurface of the rotator cuff and the posterior glenoid rim. In other terms, the deltoid muscle abducts the arm, but at 90 degrees, the humerus bumps into the acromion. Beyond this point, further abduction is the result of upward scapular rotation. This is then augmented by instability of the anterior glenohumeral joint and the tightness of the capsular posterior glenohumeral joint. From this, internal impingement could cause pathologic changes to the underlying surface of the rotator cuff, which may develop into a chronic condition in the long run if not properly treated. As previously discussed in the relevant anatomy of the patient's case, the supraspinatus muscle initiates the abduction of the shoulder. The patient reports pain on her left shoulder due to even slight movement, which is why the impingement of this rotator cuff tendons is very plausible. Aside from impingement, there could be other causes as to the pathophysiology of rotator cuff tendinitis, such as microtears or overload of the tendon's tensile strength, but we would need further examination to accurately describe the origin of injury. Other than for the supraspinatus, what other structures does the patient's condition affect? Let's find out in the next slide. Looking deeper into the condition, when it comes to rotator cuff tendinitis, the structures that are commonly affected are the muscles and tendons that encompass the glenohumeral joint, specifically the sits muscles and rotator cuff tendons. Adjacent structures such as the bursa and surrounding ligaments could also be agitated, causing a dull aching sensation upon movement or whenever lying down. This is shown in the illustration on the upper right portion, whereas you can see the different structures of a healthy and functional shoulder. Beside it is a photo of a swollen and inflamed rotator cuff, which, if you can notice, sort of disturbs its surrounding structures. But let's return our focus on the rotator cuff tendons, which are, to reiterate, the supraspinatus, infraspinatus, teres minor, and subscapularis. And we believe that we've made it very clear that even if one of these structures become irritated or damaged, this can result to tendinitis, the inflammation of the tendon as seen on the bottom illustration, and may develop into much more unmanageable conditions such as tendinosis or tendinopathy. It is also important to take note that tendons are the soft tissue that connects our muscles to the bone, allowing them to be a pulley and subsequently produce movement. Tendons differ from muscles because they are mainly made up of collagen and elastin. This means they cannot contract themselves, but they are incredibly strong and stiff. That being said, the clinical manifestation of rotator cuff tendinitis is accurate in our patient based on her complaints of limited motion and weakness of arms.
Athletes are very well versed in high-intensity workouts and living healthy lifestyles to keep them fit and conditioned for their respective sport. However, poor body mechanics and decreased flexibility and strength may result in certain injuries. In our patient's case, it is generally determined that her shoulder pain may be caused by instability coming from the functional demands that are specific to her sport of swimming. To be particular, the biomechanics of the butterfly stroke includes the increased range of motion in the upper extremities, such as circumduction, flexion and extension, as well as adduction and abduction. Since the patient is a competitive swimmer, it is unavoidable that these demands should always be met for her to continue participating in her sport. Instability in most swimmers' cases is mainly an overuse problem caused by repetitive microtrauma. For the patient, her instability pinpoints to her left upper extremities. Reduced stability can lead to subluxation, the partial dislocation of a joint, which when combined with repetitive movements can lead to the inflammation of muscle structures and pain. Moreover, female athletic swimmers usually peak during their mid-20s, which is why the patient's age may have also been a contributing risk factor of left rotator cuff tendinitis.
And that concludes our presentation. Here's the list of references used for our group's case discussion. Thank you for listening to our case discussion on the symptoms and causes of rotator cuff tendinitis. Once again, we are Group 6 from PT1A. Have a great day.